So, welcome to Billman Ultrasound Training Institute. We are today taking a session for those who are registered with us. Right now, we are not taking a course. We are taking an interactive question and answer session for our ongoing registered candidates who are undergoing different server-based courses. So, don't take this as a course. This is just a question and answer session for our registered candidates. So today we got some questions from our registered candidates. This is the list of the question over here. First question is from Dr. Papu. The question, these are the copy pasted questions. So this is as it is, we have received it and we have just copied it. So even the language is same as we got. So Dr. Papu is posting the question that what settings we do in color Doppler for measuring the proper measurement of width of vessel. Second is what setting required to measure perifollicular flow during follicular study. And in continuation is what is difference between a read zoom and a write zoom. So probably Dr. Papu is taking physics and machine settings course right now. So what I can make out from the question is that this candidate is undergoing physics and machine settings. So these are related to the physics and machine settings. We will come to these questions. So second question from Dr. Subha Patel is that, sir, can you tell us about appendicitis, peritoneal inclusion cyst, how to, and the third question is how to utilize machine settings to get scar thickness in term pregnancy. And the last question from Dr. Subha Patel is that how to get types of placenta in pregnancy. Probably this Dr. Subha Patel is undergoing the complete course and she has already completed the course. So what I can see, she's having, she's having question from multiple pregnancy and the abdominal also. So scar pregnancy is there. It means that that candidate is about to complete the course. So we will take the question of Dr. Subha Patel also. Then the Dr. Prakash Pindari is posting how to calculate volume, yolk sac, inner to inner or outer to outer. And the next question is how to locate normal and abnormal appendix. So then Dr. Nanda is posting when to say mild, moderate, and severe in case of pleural effusion and ascites. Then the next question is renal calculi mimickers in ultrasound. These are the copy pasted questions. I am reading as we have got these questions. Then Dr. Swapnil, how to trace PSV, peak systolic velocity, above 1000 centimeters in thyroid. Then the next question is to locate STA, superior thyroid artery and inferior thyroid artery. Sir, please discuss position and angling of probe while tracing a mid-ureteric calculus. These are the questions posted by Dr. Swapnil. Then Dr. Kirti. Dr. Kirti is posting for uterine artery probe should be transverse and longitudinal. So the point is, we have got these questions from our registered candidates who are taking different server-based courses. Again, repeating, this is not a course over here. What we are taking right now, we are taking the questions from our registered candidates who are undergoing different server-based courses. So, starting the session. So the whiteboard is set, and we have gone through the questions. The first question, now see, I am even having a printout in my hand of these questions. So the format, I am repeating, the format will be, I will of course take the questions, but in case anybody is having any confusion or wants any explanation, there are two ways. One is to raise the hand, not the physical hand, the digital hand. There is a more option, and in more option, there is a pop-up of raise hand. You have to click over there, and once you will click over there, a hand raise option will appear. But please make a note, if in case you are having a background noise, don't raise the hand. And the second option is the comment box. You can post in the comment box. So taking the first question from Dr. Papu is, what settings we do in color Doppler for measuring the proper measurement of the width of vessel? So the point here is that what are the settings of the machine in color Doppler? Now, you have to understand first that it depends which vessel you are scanning. But first of all, the point is, before color Doppler, you should have a proper grayscale. It means that the grayscale is the backbone of color Doppler. Don't expect your color Doppler to do miracles for you. It will work only and only when your grayscale is up to mark. What I mean by up to mark, that is in detail in your course. There are about 2 to 4 classes of settings of color Doppler. So the basic important point is, color is nothing but the superimposed color on the grayscale. That is point number 1. Now, how this is practically working, that if you are scanning now see, this is the probe over here. You are scanning, you are sending the beam, and then you are superimposing a color. You are superimposing a color box onto the grayscale without having a good grayscale image. You will struggle decades together to get the proper color, and you will not get. Now, the basic important point is that now what I mean by a good grayscale image. Now, for example, you are looking for a uterine artery. Get that uterine artery. Now see, get that uterine artery in grayscale. Get that uterine artery in grayscale first, and then only put a color. If you will not get a grayscale, good grayscale image, you will not be able to see it on color. Now, whenever you got a vessel, now whenever you got a vessel on grayscale, then only put the color on this image, on this vessel. So this is the basic important point, that your grayscale should be perfect to put the color on this. Point number second is that, now see, not always you will get a vessel, but you should have a frank idea where the vessel is. There you have to put a color. This is the point. Not searching for the vessel with color. I'm repeating, not searching the vessel with the color. You should put a color Doppler on a good grayscale image. What I mean by on a good grayscale image is that you should know that there the vessel is, which is seen clearly on grayscale or hazy on grayscale, but you should be clear with anatomy why I am putting color. Then only color will work. Color will not search for the vessel. This is the point. So color will not search for the vessel. This is the confusion among many doctors, that I will put color and color will search for the vessel. No, color will do when your grayscale is up to mark. That is point number one. Point number second is that whenever, now the point number second is that whenever you are putting a color on a grayscale image, this is very important point. Whenever you are putting a color on a grayscale image, the frame rate FR is dropping down. This we have discussed in detail in physics and machine settings, how the frame rate is affected by putting the color. So it means that after putting a color, your grayscale frame rate will drop down. Previously, if for the sake of argument, it was 100 frames per second, after putting the color, it may get dropped up to 10 frames per second. So this much the frame rate is dropping. What this is telling me, this all is telling me that first I have to get a good grayscale image, and with the good grayscale image only, I have to put the color. Now, second example. Now, I know that where the uterine artery is, I can see a uterine artery on color Doppler, on grayscale. Yes, I can see. Sorry. Now, the point is, if the vessel is very small, that cannot be picked by a grayscale, then how could I know that my grayscale is cutting through that vessel, which is very small and not picked by the grayscale? I told you that at least I should put color knowing the section where from the where the vessel is. For example, fetal head. I'm just giving you an example. I'm not teaching you right now how to take a color Doppler of the fetal head. No. I'm just giving you an example. I cannot see a small vessel, that is the middle cerebral artery, the circle of Willis. I cannot see on grayscale. Now, what about the grayscale image then? But I know that when I will go to a transthalamic section. Now, where the transthalamic section is, if you have not completed yet the fetal ultrasound, you will not understand this. The point here is, I know that the middle cerebral artery and the circle of Willis can be seen in a transthalamic section. It means that I have to be in transthalamic section only. Then I will be putting color and I will start seeing circle of Willis with a middle cerebral artery. So this is the point. So I hope that I have done with the question of Dr. Papu. Now, the second question from Dr. Papu is that how much should be the gate width? How much should be the gate width of the Doppler? Now, the gate width. Now, see, if this is the vessel, in ultrasound, there is nothing static. By static, I mean that there is no hard and fast rule that I have to be 2 centimeters away from here. I have to be sending the beam with a 20-degree angle. No, it depends. It depends what you are scanning and where you are scanning. Now, for example, there is a vessel in which I am having a 4 centimeters width. In a 4 centimeters wide vessel, my gate should be of dash dash. For example, it has to be 3. For example, just an example, it has to be 3. It will not be 3. We will come to that. But if the vessel is 2, I cannot put a gate of 3. There it has to be 1.5. So that is what I am saying you. In ultrasound, there is nothing static. There is no hard and fast rule that this gate has to be this or this gate has to be that. Now the point is, if the vessel is of this much. Now see, if the vessel is of this much can be maybe 5, maybe 10, maybe 11, maybe 2 centimeters or millimeters even. Now I am putting a gate over here. Is this a good gate? Post in your comment box, yes or no. No, wait. Let me start from here. If this is the vessel, now see, if this is the vessel, let me take another color, and this is the gate over here. And this is the gate. Is this a good gate to put for this vessel? Post in your comment boxes now, yes or no. I am waiting. Yes or no. Dr. Chintan Chaudhary, no. Next doctor is posting me, no. Dr. Komal, no. Why? Dr. Prakash Pindari, no. Dr. P. Yadav, no. Why no? Because this gate, now see, because this gate over here is crossing the vessel. My gate should be on the vessel, not crossing the vessel. That is what I told you. It is not hard and fast. I cannot say that it has to be 4.5, 4.7. No, it depends on the vessel. Now, I am putting gate over here. Now see where this is. Yes or no? Is this the gate? Good or no? Yes or no? Have to put gate like this, which is taking the vessel. Say yes or no. Dr. Chinta Chaudhary, yes. Stating yes. Next, Dr. Anusha, sorry, no. Dr. P. Yadav, no. I'm keeping an eye on the chat box. This is over here. The chat box is here. So the point is, whosoever told me yes, Dr. Prakash Pindari, yes. Next, yes. Dr. Sanjay Kumar Yadav, yes. Dr. Sanjeev Kumar, yes. No. This is not the good gate for this vessel, because this is on the walls. No. Now I will draw. You will tell me yes or no. This way you will remember, and this way you will understand. Now this is the vessel, and this is the gate. Let me take another color for the gate. This is the gate. Yes or no? Dr. Surinder Kumar, yes. Dr. Prakash Pindari, yes. Dr. iPhone, this is what is reflecting over, yes. Next, Dr. Komal, yes. Dr. P. Yadav, yes. Dr. Suresh Singh, no. Dr. Suresh Singh, only you told me no. Rest everybody. Dr. Sovit, yes. Yes, and yes. 3 times yes. Now, the point here is that my gate should be in the vessel. I should not put the gate on the walls of the vessel. It should be in the vessel. Now, in the vessel, how much? How much in the vessel? Roughly about a 70% of the vessel. 70% of the vessel. Not even touching the vessel wall. I mean, you should not touch the vessel wall. It has to be a 70% of the lumen, I mean the diameter of the vessel. So it should not be very small gate also. Now see, if the gate is this much only and my vessel is this much big. Now see, my vessel is this much big. And if I will be putting this gate, which is about a 10, maybe a 15%, no, not a small gate also. So the point is not a small gate and not a wider gate, and no way you can put the gate which is taking, which is going away from the walls, I mean, which is more than the diameter. So it should be about a 70 and 70% of the lumen of the vessel. I hope that we have done in detail with Dr. Papu's question. Now, there is one more question. Now, see, I am having even a printout of these questions. I showed you these questions in the beginning. Now, what is the difference between a read zoom and write zoom? Now, see, the point here is that we doctors from Indian subcontinent are a bit weak with physics. That is why we are struggling. That is why we are struggling. So we have to be a bit knowledgeable with the physics also. Now, I am happy that Dr. Papu is grasping things very quickly. He is probably registered with us from last, I think, not more than, this is probably the August batch only. Now, the read zoom. Now, see, the point is the read zoom produces the worst kind of image. Try to understand. The read zoom produces the worst kind of image because it relies on the stored image, which enlarges the pixel. That is the read zoom. Now the write zoom tries to maintain the pixel density. So which one is superior now, read or write? Of course, the right one. So go for the write zoom. Try to switch to the write zoom, not with the read zoom, because the pixel density is falling in the read zoom than in write zoom. So this was the detailed explanation of questions which I got from Dr. Papu. Now we will go to the next question. I mean the next candidate's question. So I'm again repeating, this is not a training course what we are taking right now, but is a question and answer session for those who are registered with us. So the next question from Dr. Subha. Dr. Subha, what was the question from Dr. Subha? I'm having a screenshot of that also. Of course, I'm having a printout also. I want you to go to the original question. Yeah, it is here. So, sir, can you tell me about the appendicitis? Now, see, the appendicitis is not included in our course, but we are going to include this appendix. I mean the appendicitis and how to differentiate whether I'm dealing with a normal appendix or an inflamed appendix, how to diagnose that. We are starting this sub course as well, in next maybe 1 or 2 weeks max. So we will take that appendicitis in great detail. In that sub course, we will you will get the notification of that. So we will be leaving this appendicitis for now because this is a separate sub course. This is not a question now. So we will take and you will get the invitation of our appendicitis class. Now, next is peritoneal inclusion cyst. Before peritoneal inclusion cyst, because this peritoneal inclusion cyst is a vast topic, it will take about 10-15 minutes. I will switch to the third question, how to utilize machine settings to get the scar thickness in term pregnancy. And the last one is that how to get types of placentation in twin pregnancy. This is the Dr. Subha, which is posting these questions. Now, one of the questions from Dr. Subha was how to utilize machine settings to get the scar thickness in term pregnancy. Now see, machine settings, whatever has been taught to you, machine settings, go to the machine settings. The machine settings is applicable for anywhere ultrasound in the body. It is not that you have to go and set a machine separate for the scar thickness, as you are setting the machine for the rest of ultrasound, so will be applicable for the scar thickness also. So I will not take it in great detail because it will take about 2 hours. This is already included in the physics and machine settings course. So I will request you to go over there. There is one class of 45 minutes, which explains the great, even the minutest detail of the physics and machine setting, not physics, the settings of the machine, how to set the machine. Set the frequency, how to set the frequency, how much should be the frequency. First, go to the this preset mode. So these all things are over there. It will take about 1 hour if I will start revising this. So better go over there. I will tell you only one thing. Set your focal zone. Focal zone is very, very important. Don't miss the focal zone. How many focal zones I should have? This is in great detail in the physics and machine settings course with the title of settings of machine. So these are applicable for scar thickness also. Now, peritoneal inclusion cyst. First of all, we have to understand what this peritoneal inclusion cyst is. So the peritoneal inclusion cyst, this is the not a question. This is not a question. This is a complete topic. Peritoneal inclusion cyst. Can anybody raise the hand so that we can unmute his or her computer or whatever device he or she is using to discuss? So please raise the hand, but please make a note that there should be no background noise from your side if you raise the hand. So I can see many hand raised over here. Dr. Bhumika Thakur, we are sending you an invitation. Once you will receive it, you have to say hello so that we can check whether your system is audible or not. Dr. Bhumika, say hello. Next, please raise your hands. Not the physical hand. There is more option. On more option, you have to hit the raise hand. So I have sent an invitation to unmute the system to Dr. Bhumika Thakur. So she is not accepting, maybe that she is having a background noise. So meanwhile, if I will get more hand raised, I already got one, Dr. Komal probably. Please hurry up. We are running short of time. We are having many questions here to discuss. So raise your hands, whosoever wants to interact with me directly. Dr. Komal, we have sent you
Yes, sir.
invitation. Say hello.
Yes, sir. Yes, sir. Hello.
Yeah. Are you a gynecologist?
Yeah.
Now we will discuss with you. Please don't raise your hands now. I needed only one candidate, and I have got Dr. Komal with me. So, Dr. Komal.
Yes, sir.
First of all, tell me, have you any idea of peritoneal inclusion cyst? What is actually this peritoneal inclusion cyst?
No, sir. No, sir.
Now see, the term itself, peritoneal inclusion cyst. Peritoneal inclusion cyst. It means that the peritoneum is involved over here.
Yes,
right?
sir.
Not always you have to copy paste in your mind. sometimes you have to think. Not sometimes, always you have to think. Now, the term itself, the peritoneum. Dr. Komal, are you registered for any course?
Yeah.
Which course?
Obs and gynae course.
Obs gynae. Okay. Now, the peritoneal inclusional cyst is a type of the cyst, cystic structure, I will say. It is not actually a cyst. Is this a cyst?
It says including something or part of a.
Yes. Now you are getting on time. Now, see, now when you are thinking, the things will come up. It
Yes.
is entrapping something. You told me just now, right?
Yes, sir.
Because the inclusion is over there. Peritoneal inclusion cyst. Something is included. What is that something? I want to hear from you.
Maybe it can be bowel.
No. Now the point is, the term itself decoded about 80% of its definition. Peritoneum.
Peritoneum.
No, peritoneum and inclusion. It is including something, and that something is ovary.
Yeah.
Got it? Now, the term peritoneal inclusion cyst is a type of a cystic structure. I will not say this is a cyst, because this is not actually a cyst. This is a pseudocyst, which looks like a cyst. It is a type of a cystic structure that appears in a relationship with the peritoneal surfaces. Is this a neoplastic or non-neoplastic?
Mainly non-neoplastic, sir.
Non-neoplastic. Very good. Now see, the point here is that now we have to understand the pathology also. If you will be understanding the pathology, believe me, you will do miracles with ultrasound. Now, pay attention to the pathology. Ovary is always and always secreting some fluid, a very minimal fluid. Yes or no, Dr. Komal?
Yes, sir. Yes, sir.
Now that, I'm simplifying the pathology. Now that fluid has to go into the peritoneal cavity. Yes or no?
Yes, sir.
Now that has to get absorbed by peritoneum. Yes or no?
Yes, sir. Yes, sir.
Now, if there will be something which will tell upon the absorption rate, the fluid will get accumulated over there. Yes or no?
Yes, sir.
That fluid can be picked by ultrasound, and that is peritoneal inclusion cyst. How it looks on ultrasound, we will come to that. But first, try to understand the pathology. Now, let us draw on the board. Now, this peritoneal inclusion cyst. If this is an ovary over here, Dr. Komal, you there?
Yes, sir. Yes, sir.
Now, if this is secreting fluid, that fluid has to get absorbed by peritoneum, which is over here.
Yes, sir.
For example, which is over here. This much of peritoneum, I mean 100%, whatever I am having peritoneum available. It is 100. Anything. 100 square meters, 100 square miles, anything. 100 I am available, and the secreted is 10 cc or mls, anything. So this 10 mls is getting absorbed by the 100 square meters of peritoneum, and nothing is left behind. Got it?
Yes, sir.
Now if I am having not 100 available, if any reason I am having only 50 square meters available, will 50 square meters be sufficient to absorb 10 mls?
No, sir.
Now there will be a pool up of 5 mls, because I am having half of peritoneum available. So now this 5 mls will get pooled over here. Yes or no?
Yes, sir.
And this is fluid. And this will entrap the ovary, because it is secreted by the ovary, it will get pooled around the ovary.
Ovaries.
That is peritoneal
Inclusion
cyst.
cyst.
Now, you will tell me what I can expect this to be. I mean, why I am having less of peritoneum? Has the rest of the peritoneum gone to heaven? Why I am having less surface area of the peritoneum? In case, now listen to me, in case I am having a patient with any surgery conducted, and that surgery will lead to some adhesions.
Yes, sir.
Now the adhesion play over. See how? Previously, I was having this much of peritoneum around this ovary. Now, due to any adhesion, which will go this way, and I'm having peritoneum here also. So now see what is happening. This sided peritoneum will not absorb the fluid of the secreted from the ovary. Yes or no? Because there is
Yes,
adhesion in between. So the available peritoneum to absorb the fluid of the ovary is this only. So that way I will be having a less of the peritoneum available. I mean for the absorption. So this is the pathology. Now apply this pathology onto ultrasound. You will yourself decode what you will see on ultrasound. I'm erasing this now. Now, Dr. Komal and others, whosoever is available with me, I am having how many? Oh my God, 53. 53 candidates I am having with me. Dr. Komal is only available with audio. Rest we have muted, but everybody, what I will expect on ultrasound image. Dr. Komal, you please play with some of your neurons and you will get it. Think. First think, then tell me any comment. Will I see any ovary?
Yes, sir.
Dr. Komal, yes or no?
Yes, sir.
Is this a functional ovary or a non-functional ovary? Hurry up. It is secreting the fluid, so it has to be
Functioning.
Functional ovary. So this is a normal functional ovary. Now, before coming to the normal functional point, I will add on one more point. Dr. Komal, you being a gynecologist, tell me very frankly.
Yes, sir.
In which age group you have seen the peritoneal inclusion cyst? You might not do ultrasound, but you are seeing a routine OPD. Was the age 40 or above or 30 or less? Recall.
40 above, sir.
40 and above. Very good.
Yes, sir.
So the patient's age will be 40 and above. It means that perimenopausal. But this is an active ovary. So the age of the patient. You have to see to the age of the patient also. If it is perimenopausal, you can think on lines of on this peritoneal inclusion cyst. Now I will see a normal active ovary over there. Now, what will be surrounding the ovary?
Anechoic
Just
fluid.
now discuss it. The pathology.
Fluid. Anechoic fluid.
Right. So fluid will appear black on ultrasound. Will there be internal debris? I mean, any mass or any debris in this fluid?
No, sir.
Very unlikely. Very good. Because this is not any pus over there. There will be a clear fluid. Yes?
Yes, sir.
Now, can I see any mass over there? Yes or no? Mass,
No,
mass.
sir. No, sir. No,
No, there will be no mass. No mass. Because I am having a fluid which is entrapping the ovary. Now, What else I can see? What else I can see? These adhesions, which is the basic cause of the peritoneal inclusion cyst. Yes or no? Adhesions. Now I can see some adhesions also. These are some adhesions. So this is the ultrasound picture. Now, where from we got this ultrasound picture? From the pathology only. Now, if I know the pathology and if I can apply that pathology onto the screen, I don't need to open the ultrasound Kalin or Fletcher book, because now the book is my brain. And these points will remain for whole life with me. So the ultrasound picture will be large, wide, irregular, anechoic cyst. Anechoic cyst. There can be some septations. There can be some septations. So see for any septations, if any. And how much can be the size, Dr. Komal? How much can be the size of that peritoneal inclusion cyst? Now you have to think. I will not tell you. Any idea? Now think first. How much can be the size of the peritoneal inclusion cyst? Think. You there?
Yes, sir. Yes, sir.
Think first, then reply. How much will be the size of the peritoneal inclusion cyst?
It will be more than the size of the ovaries.
More than how much? Double, triple, 4 times, 10 times? I am again repeating the pathology. Now listen to the pathology. Again, this peritoneal inclusion cyst is nothing but the fluid,
Yes,
which
sir.
is entrapped due to some adhesions. And now it depends. I'm just recalling you the pathology. Now it depends how much fluid I can see over there. It can be this much. It can be this much. It depends on the absorption, I mean the reabsorption rate, and it depends on the available peritoneum with me. Now come back to ultrasound. How much can be the size of the peritoneal inclusion cyst? Anyone? In comment boxes now, please. Dr. Komal, you please continue thinking. How much can be the size of the peritoneal inclusion cyst? Will it be 1 cc, I mean 1 centimeter, 10 centimeter, or 100 centimeters? Others, please comment in the comment box. Dr. Chetan, 5 centimeters. Next. Hurry up, hurry up. Dr. Gayatri, 10 centimeters. Next. Dr. Komal, you
Yes,
with
sir.
how much? 5 or 10?
5.
No to your 5 and no to others 5 and no to others 10. Dr. Yadav, more than 5. No, 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 no. Recall the pathology. It is the fluid over there.
Yes, sir.
Now that fluid will be defined
Mild,
by
moderate, mild, moderate. Or
no. Listen. Now, if I am having a more of peritoneum available, it means I will be having less of fluid. Yes or no?
Yes, sir.
If I am having less of peritoneum available, I will be having more of fluid. Yes or no?
Yes, sir.
Now think again. How much can be the size of the peritoneal inclusion cyst? It depends on the reabsorption rate. It can be 1 centimeter or it can be 100 centimeters. There is no fixed when I am differentiating the malignant cyst from a benign cyst. There we are having 10 centimeters. No to peritoneal inclusion cyst. It can be even in millimeters, very, very small, and it can be as big as it is taking whole of the pelvic cavity. So now if you will be seeing a very small cystic, not the cystic structure, fluid collection. It can be the peritoneal inclusion cyst. But if you see everything is taken by this fluid, that can be also. So the size is not fixed over here. It can be 1 centimeter, or it can be even more than, and maybe 20. It can go up to any limit. So size is depending. It can be very small. It can be very, very big. And there will be no mural modalities. So I mean that there will be no solid component in that cystic structure. If you see a solid structure, then it is going against the this peritoneal inclusion cyst. And there will be very minimal internal debris. So almost it will be a clear fluid. Now, spider web pattern. The books are writing the spider web pattern. What is that spider web? Now see, these adhesions, when seen on ultrasound with a clear fluid, it will look like a spider web. So these spider webs are nothing but these adhesions, what I am seeing arising within the cystic structure. Okay, so treatment, is most of times the conservative treatment. So this was in detail the peritoneal inclusion cyst. And this appendicitis, we will take separate course. Right now we are taking the question and answer session. We will take a separate course, and you will get an intimation of this appendicitis in your WhatsApp groups. Okay, so now the next question. What was the next question? What is that? Yeah. So the next question, we are running short of time now. Again, Dr. Subha is telling me the type of placentation in pregnancy. This is in detail in your multiple pregnancy course. So probably Dr. Subha has not completed the multiple pregnancies. So that is why this placenta, types of placenta is arising over there. So I will give a very brief see for the uterus, see for any intervening membrane over there. If I will be having one placenta over here, this will be anterior. If I will be having next placenta, this will be posterior. So you can make it out that fetus number 1 or the fetus which is in breech presentation. This is all discussed with you. Maybe that you have not completed the multiple pregnancy, you can make it over here that this is anterior and another is the posterior. But the problem is not with anterior and posterior. These are very clear. But the point is, if both will be fundally, now see, if both will be fundally here. Now let me take this on next slide. If this is the uterus and I am having one placenta over here, and next placenta is next to this, I cannot see both placentas separately. It will look like one placenta only. So this is a fused placenta. The problem is with fused placenta in case of the multiple pregnancy. This is in great detail on server. Now here, how to make out that these are actually two placentas, the fused placentas, and not one? Please post in the comment box. Dr. Komal, if you have any idea, you tell me. How to make out that I am having two fused placentas, which are not actually fused. They are very close to each other and they looks like fused. Now question, how to make out that these are two fused or close lying, I will not say fused, very close lying placentas, and they are, this is not a one placenta. Any idea? Hurry up. in comment boxes now. I'm going to the comment box. Intervening membrane thickness, very, very good. Dr. Anusha, Dr. Gayatri, T sign and lambda sign, very, very good. Now here what I have to see, that how much is the intervening membrane. If I am having a thick intervening membrane, it will be accordingly. If I am having a very thin, I will not start over here with the multiple pregnancy because it will take about 4 hours. It is there on the server. So if I am having a thin or thick, so I have to see whether I am dealing with a thin or thick membrane. Then I have to see for the T and the lambda sign. And if I got a lambda sign and I got a thick membrane, then these are 2 placentas looking like one. For more details, please refer to the physics and no, not physics, the multiple pregnancy course from the server which you are already registered for. So, and if you have completed that, please revise that. The things will get clear. Now, Dr. Prakash Pindari is having a question over here. Dr. Prakash Pindari is having a question. What is the question? Yes, Dr. Prakash Pindari, how to calculate a yolk sac, inner to outer or outer to inner? So again, the question, next question, how to locate a normal and inflamed appendix. I told you we are taking a separate course on this appendix. You will get update of that. So I will take how to calculate yolk sac. I mean inner and outer or outer to inner. So I got this question from your batch and about 3 persons are sending me the same question, whether it has to be outer to inner, inner to outer. So let us take that thing. The point here is that whenever I got a yolk sac, now why this question is coming? I can smell your brain from here because you are already taking the fetal ultrasound and you are now thinking, why you are thinking outer to inner, inner to outer, because now you know that when I am taking the BPD, it has to be inner to outer or outer to inner. It means that I have to include one side bone. I am telling you for BPD, it is one-sided bone, inner to outer or outer to inner. That is why now you are thinking the same thing over here. Is it outer to inner, inner to outer? First thing, make it very clear. Make it very clear that I don't have a bone over here, this much thick bone I don't have over here. I don't have a very thick wall over here. I am having a very thin wall. Even if I will include or exclude this, it will hardly make any difference. I mean for yolk sac. But for fetal head, it will make a difference because here I am having a bone which is thick and here I am having a very small thin wall over here. If I will include or exclude it, that will hardly make any difference. But if I have to be precise, it has to be inner to inner. If I have to be precise, so it is inner to inner. But make a note that this is very small, not small, the thin. It is not the bone which I am dealing with. So to be precise, it is inner to inner. This was Dr. Prakash Pindari's question. Now, when to say mild, moderate, severe in case of peritoneal pleural effusion and ascites. Dr. Nanda, renal calculus mimickers in ultrasound. Now see, the point here is what the question is. I am putting you the question also, but I am summing up the question. When to say mild, moderate, severe in case of pleural effusion and ascites. Now see, the point here is that you cannot make a diagnosis of mild, moderate, and severe on basis of ultrasound. I mean the ascites. You cannot make out a diagnosis of mild, moderate, and severe when we are talking of ascites. Okay. Now, the point here is that I have to see clinically patient also. So the mild ascites, mild, the severity of ascites, the mild one is when I am having puddle sign positive. That is mild. And a detected ultrasound, ultrasound detected minimal fluid, very minimal fluid, which is detected by ultrasound only, very, very minimal, but there should be the puddle sign also. Puddle sign also. Now, moderate. Moderate is when I am having shifting dullness. Now, the clinically, this is clinical thing. When I am having shifting dullness, but no abdominal thrill. That is moderate. Now, for this severe, the fluid thrill has to be there. Fluid thrill and respiratory difficulties also. Now, you have to see the patient to label this as mild, moderate, and severe. Of course, you can make a visual impression also on ultrasound when you will be scanning many patients. You will say that there is a minimal fluid, but mild and moderate, you will get confused always. Oh, sorry, moderate and severe, you will get confused. There comes the fluid thrill and the shifting dullness. I am again repeating. Mild is when I am having puddle sign positive and a minimal detected ultrasound fluid. Moderate is when I am having shifting dullness. Note it down. When I am having shifting dullness and there is no fluid thrill, that is moderate. And if there is a fluid thrill with respiratory difficulty, that will be severe. So this way, we can make out whether we are dealing with mild, moderate, or severe. So what was the next question? The next question is how to trace the peak systolic velocity 100 centimeters per second in thyroid to locate the STA, I mean the superior thyroid artery and inferior thyroid artery. Now see, the point here is that you have to now go back to the anatomy. The question is how to locate the inferior thyroid artery and how to locate the superior thyroid artery. Before that, the question is the peak systolic velocity, how that is important in thyroid scanning. So I am summing up the question. The point here is that I have to go back to the anatomy over it. Anatomy, pathology, gynecology, everything comes in ultrasound. Now, see, I have to again go to the board. Now, recall the aortic arch. Recall the aortic arch. I am having an aortic arch over here. In this aortic arch, I am having left sternocleidomastoid artery, which is going from here. Then I am having, this is the left one. Then I am having the right. You have to go to the anatomy and you have to revise this now. Go back to the first year MBS. Right? Yes, you have to. Then I am having the brachiocephalic trunk from here. I am having a brachiocephalic trunk. Now from this brachiocephalic trunk, I am getting the right artery and I am having a common carotid artery. So the right Clavian is coming from here, from this This is the brachiocephalic trunk. BT I will write in short. So here comes the carotid artery. So this is the carotid artery. And this sided carotid artery is directly coming from the, oh, sorry, no. Now let me draw first the thyroid over here. Then the things will be clear. Now in thyroid, I am having superior and inferior artery. This is the question, how to trace this. Now the superior thyroid artery is coming from the external carotid artery, So here comes the carotid artery, and this is coming this way. This is inferior thyroid artery, and this is the superior thyroid artery. Now keep this in your mind. I'm not drawing whole of the anatomy over here because it will take again 1 hour. So you have to go to the anatomy and you have to make out that the this internal thyroid artery is arising from the common carotid artery, and the superior one is coming from the external carotid artery. Yes, external carotid artery. Now, whenever, now see why I'm paying more time on to the anatomy, because anatomy will make it clear. Now, whenever I am in common carotid artery, how to trace it? This is very easy, and this is already in the course. Now, whatever will arise from the common carotid artery has to be the thyroid artery. Now, the common carotid artery. Now, question: common carotid artery is going. Now, let me draw that also. Common carotid artery. Now, see. Common carotid artery. This is the common carotid artery over here. This is the common carotid artery, and this is the inferior thyroid artery. Keep this thing in your mind. This is like this. So this is perpendicular. Now let me draw this thing on the next board. This is going like this. And this is the branch of this internal inferior thyroid artery, and this is the common carotid artery. Now they are at 90 degrees to each other. Now ultrasound. Can I see on ultrasound the picture like this? Or like this? Question: A or B? They are perpendicular to each other. Will I see on ultrasound like B or like A? Pay attention to A and B. Put it in your comment box. Comment box, open. A or B? A or B? Hurry up. A or B? I was expecting this thing. Everybody. Dr. Gayatri, Dr. Yadav is posting, Dr. Sanjeev is posting, Dr. Chintan is posting, Dr. Prakash is posting. Only, hold on now. Hold on. I got about a 98% favoring A. This. And only one favoring B. Dr. Sanjeev is with B. Rest, everybody is with A. Thank you. It is A. It is A. One in length and another in transverse section. Now you have to put your physics. Now see, this is the physics. This is the physics over here. You have to put your physics and the previous anatomy onto the ultrasound. Then only it will work. So this was Dr. Swapnil. This was Dr. Swapnil's question. Now the last question from Dr. Kriti. From Dr. Kriti, I am also showing you. I have showed you these questions. So I will show you again. The question is, so this is the last question. So we have taken all these questions. So this is the last question from Dr. Kriti. For uterine artery Doppler, probe should be in transverse and longitudinal. Now you have to put your physics. I'm giving you a clue. You have to put your physics. So this is the tip. You have to put your physics, then you have to give me the answer. Have I to put probe like this or like this? Transverse or longitudinal? Now you will reply in the comment box. Hurry up, please. Okay, so again repeating, the question is whether I have to put the probe transversely or longitudinally. Dr. Kriti and others, please pay attention. Whenever I am taking, not coming? The board is coming? Yes or no? No, it is not coming. No, it is not coming. Now it should come. Yes. Is it come? Yes. Okay. Longitudinal. Wait. Transverse, Dr. Chitan. Transverse, Dr. Prakash. Oblique. Next. Hurry up. Oblique, Dr. Prakash, Dr. Chitan, transverse, Dr. Gayatri, making an angle, Dr. Sanjeev Kumar, longitudinal, Dr. Sunita Pawar, longitudinal, Dr. Mona. Now see, somebody with longitudinal, somebody with transverse, somebody with this, somebody with 40 angle, somebody with 50 angle. No. Now, please don't draw on the screen. Please don't draw on the screen. Now see, the point is, please don't draw on the screen. So now if vessel, now see, if vessel is like this means like this. What is this? This is now at an angle. If I will make an angle with the midline of the body, this is maybe 20 degree, maybe 20 degree, maybe 15 degree. It means for this vessel, I have to keep it 20% longitudinal. But the point is 20% angle. But the point is it will be a longitudinal one. But the basic important point is that I have to see to the vessel on the screen. First on grayscale, what we have discussed it, first the grayscale, then I have to put a color. I have to put, now the answer, I have to put the probe as per the length of the vessel. So the answer is it has to go along with the vessel, along with the axis of the vessel, I will say. So this is the probe over here. Please don't draw on the screen. Whosoever is drawing is disturbing me. Now see, it has to go along with the axis of the vessel. So the angle will be decided by the vessel, axis of the vessel. So, but it will not be a longitudinal, it will not be a transverse, it will be an oblique. But how much oblique, that I am explaining. How much oblique, 20 degree, 50 degree, 16 degrees, that we cannot say. It depends on the vessel axis. So I have to see to the axis of the vessel. So the basic important point here is that I have to see to the axis of the vessel. The axis of the vessel will define the probe positioning. Not only for, this is not true only for the uterine artery, this is applicable for whole of the Doppler. So I have covered all questions. Thank you very much for being so patient. My answers are always very detailed. So it took me about more than 1 hour. Yeah, more than 1 hour to elaborate, to give answers for 1, 2, 3, 4, 5, 6 candidates questions. So there were about 10, 15 questions. So thank you very much for being so patient with me. So again, repeating, this is not the session. I mean, this is not the course right now what we are taking. The course is completely different. Right now, we are taking only and only questions. We have taken only and only questions from our registered candidates who are registered for different server-based courses. Thank you very much. And those who are registered with us will get the recording now. So the beauty of the server-based courses is that whenever you are taking these server-based courses, in case you are having any question, you are posting the question, and there is no compulsion that you have to be online. Right now, whosoever is online is interacting with me, but you will get the recording. It means that whosoever is registered with us will get the recording of this question and answer sessions also. So thank you very much. God bless all of you.